Okay, let's get started with this Chapter 9 podcast involving ambulatory care. This podcast covers 22 pages in the textbook. We have quite a few slides this time, 45 in all. It's one of the longer podcasts. We have 7 objectives that you can see here that we're going to be addressing, and we have 6 IRATs. We will also cover during this podcast. One thing I do want to note before we even get started is that there's 2 tables in this particular chapter, Chapter 9, Table 9.1 and Table 9.2, that I would like you to take a look at. The first involves the distribution of selected chronic conditions by age, categories in outpatient department areas. Please take a look at that. And also Table 9.2, which involves the top 20 most frequently mentioned drugs by therapeutic drug categories. My guess is you will cover this during the clips coming up, but it is something that you need to know not only in this chapter, but in other areas of the curriculum as well. There's 2 other tables, Table 9.3 and 9.4, involving clinics visited and expected source of payment. Although these are important, they're not as important as the first 2 tables. First of all, let's get started with the definition of ambulatory care. It's care for an individual presenting for personal health services who is neither bedridden nor currently admitted to any healthcare institution. Since managed care and drug reimbursement groups, ambulatory care services in outpatient settings have grown in importance in healthcare, especially as a cost containment measure. In other words, it's saying that because these DRGs are imposed on hospital patients coming into hospitals, the government will only pay certain amounts for Medicare and Medicaid patients, that a lot of this care has been shifted to the ambulatory care environment. Again, in an effort to keep costs down. Its impact involves common disease states on medication use. The majority of diagnoses and prescribed drugs come from a few common disease states like diabetes, asthma. There's different types of ambulatory care involving private medical office practice, non-physician practitioners like nurse practitioners and physician assistants, and hospital-related involving clinics and emergency departments. These are considered ambulatory care when they come in, for example, to a clinic or an ER or a doc in the box. There's different types of ambulatory care. We're still talking about freestanding medical services, primary care, urgent care, retail clinics, ambulatory surgery, and community health services and public health. There's different types of medical practice, including solo, 1 physician, partnership, 2 physicians, group, 3 or more. They have formal sharing of resources and income, and it may be multi-specialty. There's also managed care organizations, including HMOs and PPOs, that are involved in this ambulatory care. Managed care organizations, MCOs, it involves the identity of practice, is independent of the physicians in it. There's HMOs where the health plan that prepays providers by capitation. So, for example, a physician would get so many dollars for each patient that he or she serves. Patients provide a copay at time of service. It might be, $10, $20. Then there's preferred provider organizations that are contracted by a health plan to provide services, and there is a negotiated discount for services. Then there's this transition from solo to group medical practice until the 1930s. A solo practice of physicians was dominant. In 1932, the Committee on the Costs of Medical Care report recommended group practice as an economically efficient. It promoted insurance to improve access. In 1937, the AMA and the group Health Incorporated, GHI, there was a legal battle. The AMA encouraged denying of hospital privileges for GHI salaried MDs. The AMA was found guilty of monopoly conspiracy. There's different advantage of the group practice, after hours and vacation coverage. There's shared office overhead, personnel, and technology. There's peer consultation, and there's also medical and insurance is encouraged for group practice. The patient-centered medical home, PCMH, team-based model of care led by personal physician providing coordinated care throughout a patient's life, including linkages with other professionals for preventative, acute, and chronic illness and end-of-life assistance. There's the patient-centered primary care collaborative, which involves primary care physicians, pharmacists, and insurers. This all came about as a part of the Affordable Care Act. There's this transition to the PCMH still going on with payment reforms, highly motivated physicians, redesign of staff roles and care processes, health information technology, and other support. Again, with the implementation of the Affordable Care Act, this is still going on. The Accountable Care Organization is all part of this. It's a legal entity including providers and suppliers to coordinate care for Medicare beneficiaries and may be accountable to meet Medicare quality measures. The provider payments combine fee for service with shared savings bonuses linked with quality standards. And the goals are timely, appropriate care, avoiding duplications, medical emergencies, and hospitalizations. The ACA, the Affordable Care Act provisions supporting the PCMH. PCMHs are ideally primary care component. They expanded the Medicaid eligibility. Medicare and Medicaid payment increases for primary care and preventative services. The pharmacist's role in all of this involves that pharmacists can have a role because it requires a team-based approach, including nurses, physicians, and other professionals, should and have a medication therapy management role in this model. They typically have been underutilized in this model, and there's a great potential to demonstrate their professional expertise in this model. Teaching hospital clinics in the 1800s, clinics were poorly staffed, and dispensaries for the poor. Today, clinics function as group practices. There's three types: the medical, the surgical, and the specialty. Continuing with this, there's supervised teaching opportunity for students and residents. There's lower cost to patients is the trade-off for teaching, usually for low-income patients, and follow-up visits are also part of this. Ambulatory surgery centers were established in the 1970s, either hospital-related or freestanding. There's anesthesia advances were one of the primary drivers. Surgeries and procedures not requiring admission. Patients go home the same day as the procedure. Less time, lower cost, high level of patient satisfaction. And it's also covered by third-party payers like Blue Cross Blue Shield. There's also accreditation of these ambulatory surgery centers by Medicare and the Joint Commission. There's the hospital emergency department. It involves ambulance and life flight services like helicopters. They're staffed and equipped for life-threatening illness and injury. They have physician and nurse specialists, and a third of the visits involve injuries, poisonings, and adverse drug events. There's also, as part of these hospital emergency departments, there's community safety nets. The visit rate of uninsured higher than insured. They involve visits that are increasing for the older population. There are physician referrals, off hours, and office scheduling. Much inappropriate use of non-urgent care. Again, with hospital emergency departments. Oh, wait a minute, I forgot to say one thing. Back here on this slide, community safety nets, there is actually an IRAT that comes from this particular slide. You need to know that to reduce healthcare costs, the patient should avoid the hospital emergency room for a non-urgent problem and should go to a physician office, urgent care center, or clinic setting instead. So again, trying to get rid of this non-urgent use of these ERs. Continuing on, most community hospitals have emergency department rooms. There's three types of cases: emergent, which needs immediate medical care; urgent, that needs medical care within hours; and non-urgent, which again is a problem in emergency departments, minor or non-acute in severity. Highly used ERs are highly used for non-urgent visits, like a child with a cold. It could be managed at more cost-effective venue like a physician's office, and it's frequently used by patients with no regular physician or less ability to pay. There's also freestanding facilities. These are non-hospital-based facilities. They're owned and operated by hospitals, physician groups, corporate chains. These also involve urgent care, retail clinics, ambulatory surgery centers, federally qualified health centers, public health ambulatory services, and not-for-profit agencies. On this slide, we're talking about urgent care centers. They first appeared in the 1970s. Their ownership was for-profit physician groups, managed care organizations. They provide walk-in, extended-hour access for acute illness and injury care that is either beyond the scope or availability of primary care practice or retail care. It involves episodic care, after hours, and non-emergency. There is an IRAT that comes from this particular slide. You need to know that an urgent care is best described as care provided on a walk-in, extended hour basis for acute illness and injury that is either beyond the scope or availability of a primary care practice or retail clinic. Again, you need to know this for an IRAT. Urgent care is best described as care provided on a walk-in, extended hour basis for acute illness and injury that is either beyond the scope or availability of a primary care practice or retail clinic. Now, moving on, urgent care centers are staffed by primary care physicians, nurses, lab personnel. Self-pay insurers usually reimburse, but it depends on the third-party payer and the urgent care center. They attract paying patients, leave the poorest for hospital emergency departments and clinics. Retail clinics first opened in the year 2000 in Minneapolis, St. Paul grocery stores, operate in pharmacies like CVS, Walgreens, etc. I should say in some of these pharmacies. They're smaller scope than urgent care centers. They have triage software that helps manage diagnoses, and they're staffed by nurse practitioners, physician assistants, and MDs on call. So, like Walmart is, and some of the Targets are also getting into this. There's strong patient insurer acceptance. Some insurers waive it, or they have lower copays. The Academy of Family Physicians recognizes the need. There are physician opportunities. It urges referrals and quality guidelines for these retail clinics. There's government programs involving these federally qualified health centers. In the 1960s, the U.S. Office of Economic Opportunity, Urban and Rural, initially called these neighborhood health centers. The Affordable Care Act funded these expansions. In 1974, there was also the Community Health Centers Act. It got it going when the ACA took over more recently. There's the Community Health Centers Act, renamed the Community Health Centers. The FQCHs are federally qualified CHCs that meet federal standards. They serve about 20 million patients. The 2/3 of these patients are uninsured or Medicaid, safety net, high poverty levels, excessive infant mortality, sliding fee payments for paying patients. But again, these Community Health Centers Act was to help the 20 million that are uninsured or on Medicaid. The Community Health Centers Act mandated services including diagnosis, treatment, consultation, laboratory and X-ray or imaging services, medical and dental services, and pharmaceutical services. There's also the Indian Health Service. Treaties signed with Native American tribes stipulated the provision of certain medical and hospital services. It's managed by the Department of Health and Human Services, in particular the Public Health Service. There are 49 hospitals and 180 ambulatory health care centers under the Indian Health Service. It covers American Indians and Alaskan Natives on or near reservations. And on this slide, we continue with the Indian Health Service. The majority of IH pharmacists are PHS commissioned core. We've talked about that before in class. There's pharmacy innovations that include filling prescriptions directly from the patient's chart. There are private counseling rooms, and there are primary care to ambulatory patients with acute and chronic diseases that are involved, provided by pharmacists. So on this particular slide, you see the third IRET. You need to know that major innovations in the Indian Health Service that set the stage for active pharmacist patient role in ambulatory care included filling prescriptions from the patient's chart, the private consultations and rooms, and provision of primary care to patients with chronic health problems. So this really When you see the IRAD, it's kind of a trick question. You need to know that all three of these are pharmacy innovations. Moving on to the public health services, the colonial era, there were a charitable tradition by cities and states. State and local governments' roles and public health departments led to tax-supported departments of health, public health, services that private practice medicine had little interest in, including immunization and infectious disease case finding and control. It filled service gaps for needy and Medicaid patients, including family planning, high-risk pediatric care, and prenatal care and well baby care. There are also, for involving health department services, there's 4 categories: communicable disease control, involving contagious diseases, sexually transmitted diseases, STDs, maternal care and child care for low-income families, prenatal care, and well baby care. And continuing with 2 other categories, you have chronic diseases, which involve preventative care, screening, and general ambulatory care involving low-income patients in underserved areas. We can also discuss prison health services through the Federal Bureau of Prisons, hospitals with clinics for ambulatory care. There's full-time pharmacies at larger prisons that are involved in the distribution of drugs from the drug formulary, and chronic care clinics, including HIV/AIDS. There's also non-for-profit voluntary agencies. These are cause-related, often grassroots missions. There's repositories of community values and charity. They fill gaps for special needs populations and advocacy. They're governed by volunteer boards of directors, and it involves education, medical care, and advocacy. Some examples are the American Red Cross, the Salvation Army, and church missions. Their funding is through government and private foundation grants, private donations, Medicare, Medicaid, private insurance, sliding fee scale. So you see a lot of these right now with disasters around the country. There's school health clinics that provide health education for students. They maintain a safe and healthy school environment. And there are some personal health services. I should also mention mental health services. On this slide, there's 5 characteristics of free clinics. There's a physical facility. There are trained health personnel, usually volunteers. It's available to all. There's specified hours of operation. There's no set payment required. Small fees or donations may be requested. Also with these free clinics, there's major obstacles. There's financing issues. There's staffing by voluntary health professionals that may be sparse. Today, many remain under the name of free health clinic or free medical clinic. Some have evolved into CHCs that we discussed before. Ambulatory pharmacy services, these are hospital outpatient clinics. There's consultation and counseling, chronic disease pharmacotherapy management. They may also be involved with primary care and family practice clinics. There's interdisciplinary practice with other providers. Usually you have collaborative practice agreements, but this depends on the state law. Community pharmacy involves dispensing services, and there's also diversified services, again, depending on state law. pharmaceutical care or pharmacist patient-centered care. There's retail clinics that provide convenient, inexpensive care for minor ailments, and they're staffed by nurse practitioners. And there's medication therapy management for chronic disease and multiple medication management. So from this particular slide is the fourth IRAT. Terms used to describe the pharmacist's involvement in patient care include pharmaceutical care, clinical pharmacy, pharmacist patient-centered care, and medication therapy management. All four of these terms are used to describe the pharmacist's involvement in patient care. So there's no exceptions. All four: pharmaceutical care, clinical pharmacy, pharmacist patient-centered care, and medication therapy management are all used to describe that involvement. So it may seem like a trick question. On this particular slide, we talk about community pharmacy studies that document and assess pharmaceutical care, like the Asheville Diabetes Project, the Diabetes 10 City Challenge, and the Project Impact. All of these document and assess pharmaceutical care. Medication therapy management studies involve the Asheville Asthma MTM Project, the North Carolina State Health Plan MTM study, the Minnesota MTM study, and the MTM meta-analysis study in outpatient settings. Now, for this particular slide, you'll find the sixth IRAT. You need to know that pharmacists in the Asheville Diabetes Project who provided patient care services to patients with diabetes experienced positive outcomes, including both a reduction in A1C concentrations and an improved satisfaction with pharmacy services. Again, you need to know that pharmacists in the Asheville Diabetes Project who provided patient-centered care services to patients with diabetes experienced positive outcomes, including both a reduction in A1C concentrations and an improved satisfaction with pharmacy services. Going on with these community pharmacy studies, multiple studies have been done to assess the clinical, humanistic, and economic impact of pharmaceutical care. Researchers need to continue their work to further document the effectiveness of the pharmacist's role in ambulatory care. And the fifth IRAC comes from this. You need to know that reasons for pharmacists, well, the last IRAT, I should say. The last IRAT, reasons for pharmacists' involvement in providing patient-centered care include pharmacist, the fact that the pharmacist is the most accessible health professional to the public. They are averting drug therapy failures, and the pharmacist is one of the most trusted professionals. So all three reasons: pharmacist is the most accessible, they avert drug therapy failures, and the pharmacist is one of the most trusted professionals. All of these are reasons for pharmacists' involvement in providing patient-centered care. And again, that may come across as a trick question, but you need to know that all of these reasons are correct. And finally, conclusions. Continued expansion and business opportunities. There's this shift of growth from hospitals to freestanding facilities that will continue with health advances and cost reduction initiatives. And ambulatory care is the consumer preferred option. And that ends this slide.